So can you make it full screen your presentation?
हाँ कर दीजिए सर का presentation.
So we can start.
Now we are live. Rukiya.
Yes. Yes.
Okay. Again, sir, welcome on behalf of Pfizer. And today's we have very eminent faculties, and they don't require any introduction. We have Dr. Danny Gupta, a senior consultant medical oncologist, Dhamsala Hospital. Dr. Hakim Ansari, who is working as a medical oncologist at Fortis Hospital, and Dr. Varun Goyal, senior consultant, Department of Medical Oncology, Rajiv Gandhi Cancer Institute. Now, I would like to request Dr. Danny Gupta, please start, sir, this meeting, sir.
Rajiv, my slides are visible?
Yes, sir. Yes, sir. Absolutely visible, sir.
So sorry,
They are making, sir, on play side. Rukiya?
Yes, sir.
Yeah.
It's it's on full screen mode. Yeah.
Now it is on full screen mode, sir.
Yes.
sorry, I missed the initial part. Should we start?
Yes, sir. Please, sir. Please start, sir.
Yeah. So at the outset, I thanks Pfizer for giving me this opportunity to discuss about this relatively newer molecule, that is lorlatinib. Its usage as a frontline setting in ALK rearranged non-small cell lung cancer. So I believe we have with us Dr. Varun Goyal and Dr. Hakim. And maybe from the company side, we can put their input. So to begin the talk, so first there is a division in this way in my presentation. First and foremost is the incidence, what are the various treatment options, and then targeting the CNS disease, because these ALK positive NSCLC, we know that around 20 to 30% patients can have CNS involvement at the baseline setting. And even during the course of treatment, we can say incidence reach up to 50 to 60%. And how to manage those CNS disease at the baseline or during the course of treatment. And what are the treatment strategy in view of sequencing? Because we have so many options, like EGFR TKI, we have options. So there is a debatable whether we should use the second or third best drug, better drug in the sequential mode or upfront setting. So similar sort of things we are going to discuss in ALK rearrangement setting, whether second generation, third generation TKI are better to use upfront or in the sequential manner. So in between, we will discuss the CROWN trial, which is the main phase 3 data for regarding this lorlatinib in this setting. And last but not the least, managing the side effect profile. So incidence wise, we know that Globokine 2020 data, it has been discussed quite oftenly. So it is the second most common diagnosed type of cancer if we talk about all the cancers which we are dealing with. And it is the also leading cause of cancer death in 2020, because we have up to date at least updated data of 2020 only. So around 1 in 10 patients with cancer are like dying, 11% incidence. Incidence, and 1 in 5 cancer death are there out of all these things. So anyway, these are simple basics. We all know that most common is non-small cell lung cancer. If we broadly divide into two settings, small cell versus non-small cell, roughly 18% are the non-small cell and 20% rest is the small cell variety. Among the non-small cell carcinoma of lung, we have most common varieties adenocarcinoma, and then squamous cell carcinoma, and then large cell carcinoma. And maybe there is some percentage of other type of variety. And on the right side, we can see the pie chart in which they are showing that Globocan, as per Globocan 2020, obviously we have breast is the highest in number as per the incidence, 11.7%. Then comes the lung, it's on the second, 11.4%, just 0.3% behind breast cancer. And then the rest of the cancer comes down the line. So NSCLC accounts for 80 to 85% of all lung cancer cases, and 5-year survival rate is 26% for all NSCLC patients, and only 8% for those who are diagnosed with distant metastasis. Means the patients, if they diagnose at stage 3, stage 1, 2, and 3, so they including 4 also, if include all the stages together, so 5-year survival is 26%. But with the patient stage 4 distant metastasis, it's only 8%. So this is regarding Indian data about the India as per the global same data, as per the same data. So it is the 4th most common cancer diagnosed in India, and with distant metastasis, roughly 44% patients are diagnosed in males. On the other hand, 47.6% in female. So this is about Indian demography. And if we talk about mortality in India, in our country, it's approximately 7.8% of all cancer-related deaths are there because of lung cancer. Now, so we all know that lung cancer is nowadays, it's not just one cancer and we are treating with chemotherapy. So we have come a long way in last, I would say 15 years. Apart from chemotherapy, we have so many options, and molecular targeted drugs are there, and therefore testing is also evolving. So basically it's a both way around vicious cycle. One way, more and more standardized testing are coming, and more newer molecules are also coming into the market. So we can discuss all those things. So earlier we used to have just, I think in 2019, we used to have group 7 biomarkers. They were EGFR, ALK, Roche, I would say MET, RET, HER2. So there were 7 markers. But now I think this umbrella is evolving, and more and more labs are coming up with the broader and broader panel. So, if we include more and more panels, so we are more likely to pick up more mutation, and we can hit that target. So basically, most common target, we know that EGFR mutation, and the second most common variety which we are seeing in NSCLC patients, it is ALK gene rearrangement. So it is second most common, and incidence wise, there is a broad range, 1.6 to 11.7% of all non-small cell lung cancer. Actually, when this whole story of ALK mutation started, I think around 10 years back. So percentage, that time we used to say just 1 or 2%. Slowly, as the testing is evolving and standardization is improving for those testing, so we see that incidence of ALK gene rearrangement is increasing day by day. So earlier, when we started, it was around 1 to 2%. Then they say it is around 3%. Then data came for about 5%, then came for 7%. And now, if they are showing now, it may be for 11 to 12% in some of the studies. So this is the idea of evolution. And on the right side, we can see that there was a mutation, as I was discussing. A lot of mutation we can find out on molecular studies. So EGFR was the most common druggable target, that was 23%, and second most common druggable target was ALK. It is about 7.9%. As per this particular data, which was published in 2015, I'm sure after that, a lot of data has come up, which has set up to 12%, we can say, ALK gene rearrangement. And after that, there are BRAF 2.6%, HER2 2.7%, MET, they are even less than 1. So this much is the frequency of all these druggable targets. So now, if we are going restricting our talk to ALK gene rearrangement for this hour. Approximately 5% of all non-small cell lung cancer cases are typically adenocarcinoma in histology. Basically, these are clinically enriched population, which we used to discuss for EGFR earlier. So they are most likely found in adenocarcinoma. typically non-smoker or maybe light former smokers. They tend to occur in younger patients, and sensitive and specific diagnostic testing techniques are available. EML4, ALK, and EGFR mutation are mutually exclusive. If we find EGFR mutation, we are not going to find ALK anyway. And if EGFR mutation is negative, then there are chances that we can find the ALK mutation. So, and EML4, ALK, they are different level rearrangement. Therefore, different variants of this thing partnership are there. And I think this is not to be discussed in this. And basically, what is EML4 ALK? We all know that there's a gene breakage and there's an inversion of the segment, and inversion in such a way that EML4 part of this gene on the right side, on the left side, combined with ALK variant on the right side. So in the middle one, if you see the bar, in the middle one, we have the combining part that which called a fusion between EML and ALK gene rearrangement. So this is the main mutation in second most common mutation. So then question comes, what is the incidence of ALK mutated NSCLC in your clinical practice? So I don't know, I am supposed to ask this question to our panelists or not. I don't know what is the pattern. So let's pitch in the panelist. I believe Dr. Varun Goyal is there. Dr. Varun, you are there?
Yes,
now?
sir. Yes, sir. Yes,
Yeah,
I'm here.
and Dr. Hakim is also there.
Yes, sir. Yes, sir, I'm here.
So right. Rajesh, we have two panelists, right?
Yes, sir. Yes, sir.
Chalo, let's good. So not much. So we are all learned like oncologists. I will just disclose that ALK gene rearrangement is found in more and more number of patients. So what is your thought process, Dr. Varun, about the incidence of ALK mutated? In your practice, what do you believe? How much is the like incidence as per the testing you are doing at your center?
Sir, according to literature, like we have already published incidences of these driver mutations, and in our institution, it is slightly more than Western literature. It is 4 to 6% ALK mutation we got in our center.
Okay. Okay. And what about at your place, Dr. Hakim?
Yes, sir. I do not have exact data, but I believe it is the same, almost 5-6%.
Correct. I also believe that what we are practicing, we can say up to 6 or 7% maximum. I don't know how they have put the 11.6% in the slide. So I have not come across any study which is saying beyond like 6 or 7% ALK gene rearrangement. Anyway, they will enlighten us in the end. So about the platform testing, I think there's some literature about the ambiguity. So we have 3 testing. Dr. Hakim, given a choice, if we have, someone has done the EGFR mutation testing, right? So at some remote area, they are getting EGFR easily, and even with the liquid biopsy. So if it comes negative, right? So we can think of that. Yeah, these are mutually exclusive. We can have chances of ALK gene. So what is the best investigation modality which you would like to do?
I think I would do this NGS or IHC. Yeah.
NGS or IHC.
Yeah.
Okay. Dr. Varun, your thought?
Yes, sir. Pardon, sir. Please repeat question.
Yeah. So I was just asking that once we have the EGFR mutation negative on our testing, maybe liquid biopsy or even tissue biopsy for that matter, and we are supposed to do the next level of testing, right? Sometimes at remote area, they do just EGFR. We have seen patients. So what testing you will prefer to do particularly for ALK gene rearrangement?
Sir, if possible, go ahead with the NGS in all the patients upfront. And as in our center, we have made a lung panel. It will take less time, and all these mutations, like beside reflex testing, we can just order NGS. And otherwise, obviously, if we EGFR already we got to know and we just want ALK, then we can start with ISC, and to confirm it with FISH, this may be like applied, but NGS wherever possible should be done.
Okay. So, right. So the second part, I'm not sure whether, like you're saying that first IHC and then followed by FISH. Dr. Hakim, do you agree with this sequential approach?
I do NGS. I think NGS only if EGFR has not been done. But if EGFR has already been done, then can perform IHC also.
IHC also. But I don't know, Dr. Varun, is it not that guidelines recommend FISH is the standard gold standard testing? NGS is okay if you are doing the broad panel and you know a lot of information will get. So NGS is a modality of choice. There is no doubt in that. But if we talk about IHC versus FISH, if the financial is a constraint, so is it not is not like that? Ki guidelines suggest that FISH is a gold standard.
Yes, sir, FISH is more sensitive and it will pick some 2-3%, 1 or 2% more patients. It is not like that we have to do FISH. If on ISC it is positive, we don't need. Otherwise, we can go ahead with FISH if ISC is negative.
Okay, okay. So, frankly speaking, I was not having that idea. So I think company people will let us know about this discrepancy, whether IHC first or FISH first. Because, you know, I was thinking other way around, that there was some literature which they say FISH is the gold standard. If somehow we are missing on FISH, even I have one patient, FISH was negative for ALK gene arrangement. And at some point down the line, someone did the IHC, it turned out to be positive. So
Yes, sir.
I don't know.
There are a few cases.
Yeah.
There are a few cases in which FISH may be positive and ISC is negative and other round also.
Yeah.
So that may be that may happen. Yes.
So I don't know what is the standard guideline. It is IHC followed by FISH.
Yes, sir. In our institution, we do like that.
Okay.
First and then FISH.
Right. So do the ALK variant translocation have an impact on outcome or treatment selection? I'm sure this variant translocation doesn't have any selection criteria. Do they have, Dr. Varun?
No, sir.
I don't think any translocation variant have any selection criteria.
But it may be in future because of these rare mutations. They obviously influence our treatment in the third line. But at present, there is no selection criteria at the first line, at least.
Yes, sir. There are at least 15 variants of this ALK EML4. But some studies have shown the response. They may respond differently, but others have not shown. So we cannot draw a conclusion at this time.
And regarding about so we'll come to that. After this discussion, there are some still unmet need in ALK positive NSCLC. What they want to say, this we have discussed. CNS metastasis, our baseline is this 20 to 40%, and treatment challenges even with the availability of second generation ALK resistant mutation. Yeah, mutation part I am not having any personal experience. So any of you have experience regarding mutation? Which type of mutation you have come across? Maybe first line crizotinib or second generation or third generation, either of these TKI. Any sort of mutation you have found? I'm sure Dr. Varun, at your place you must be doing.
Sir, we do different mutation testing. I don't remember, these are some numbers, but yes, in some certain mutations, initially it was like that lorlatinib is better than brigatinib, such like that. But at present, in second line, we can go ahead with lorlatinib. So maybe sometimes we just not stress upon the mutation type for the treatment part, but still different may influence the treatment.
So any particular mutation you are remembering on which basis you have decided any particular TKI?
At present, not remembering.
Not remember. No. As per literature, Dr. Hakim, you know what is the most common mutation?
Sir. As per literature, it is 1196. Some 1196 mutation is more after with crizotinib.
Correct.
And then there.
I think it starts from L1196M.
Yeah. Then there is other mutation that develops after 1202 something. Yeah.
Yeah. So that is, I think, G or R, G1202R.
Yes,
So
sir.
that is
Yes,
the,
sir.
I think that is a particular mutation on which lorlatinib does act. है ना?
Yeah.
So G1202R, I think it may come in further slide also. So yeah, so this is the part about mutations. Resistant mutation are there, and some are ALK related or some non-ALK related, not ALK related. So there are two things which are important highlighting, but in fact 3-4 points regarding this newer TKI. One is how they are acting in the intracranially, and second is the resistant part, and third is the how we can manage the side effect profile. Because there was an assumption a few years back, I think 3-4 years back, that lorlatinib has a lot of side effect. Side effect profile is of this drug is more than alectinib, and therefore there was a reluctance to use this drug. Personally, I'm not having any experience, frankly speaking, about lorlatinib. So Dr. Varun, you have about any side effect profile of lorlatinib?
Regarding side effect profile, sir,
Practically.
no, practically haven't experienced much.
Okay.
Like,
Dr. Hakim, what about you?
Practically, I have yet to use lorlatinib, but as per
Okay.
literature, we know.
So in the end, we'll ask the company people what is there and they what feedback they have from the other oncologists. So just to go ahead, testing for CNS disease in ALK positive NSC at the point of diagnosis. As I said, in the treatment naive patient, we have roughly around 20% patient with the brain involvement. So testing, we all know that MRI definitely is the best out of this CT or versus MRI. This ambiguity is not there anymore. So all the guidelines also prefer to do MRI, preferably with the gadolinium enhancement. So yeah, so this is a comparison regarding MRI versus CT. And but final conclusion is that MRI with the gadolinium enhancement is the gold standard for detecting even the minimal intracranial lesion. So how to manage those intracranial lesion? We have systemic therapy and local. We know that whole brain radiation or stereotactic focused radiation, depending on how much lesion we have in the brain. And even we can go up to, in some cases, surgical resection. So Dr. Hakim, if I ask you, any patient comes treatment naive with the brain lesion, around 4 lesion, it may be 1 centimeter, 4 lesion in the brain, and systemically also there is some bone metastasis. And we were there around 5 years back. Suppose lorlatinib we are not having. So how will you approach these patients?
I think I would give systemic treatment, crizotinib with this thing, radiation. I would have given radiation with this thing, crizotinib.
Okay. And what about stereotactic, SRS?
At our this was not doing.
Okay. Dr. Varun, SRS के लिए कोई मतलब, do you have any particular number defined?
No, sir. It is not like particular number. It's just overall volume of disease, size, and feasibility. So, like I have seen up to 5 lesion, 5-6 lesion also they have done SRS. But those then should be small size lesions. Single lesion may be somewhat bigger, multiple then smaller.
Okay, right. So I just remembered few guidelines. One of the forum we were discussing, I think number is up to 5 or 6. You said correctly, but I think there are guidelines in the radiation people. They say that up to 6 we are treating with the SRS, and obviously surgical resection. If single lesion is there, so even we can go for surgical resection. So as I asked that, when we don't have lorlatinib, so what systemic treatment would you offer, Dr. Hakim?
Crizotinib, or alectinib. If we had alectinib that time, alectinib.
So won't you prefer to sequence the drugs, crizotinib followed by alectinib?
No, sir. I would like to use most potent drug initially because there are chances of developing resistance. So when we use most potent drug initially, the resistance may be delayed.
Okay. So because why I was asking this question, because you know in the literature the mutation which we were discussing G1202R, it is most commonly found after second generation TKI. So if we
Right.
use and rarely after first line TKI. So if you use alectinib upfront, so I don't know, there's so more mutations, like even complex mutation, chances of complex mutation are more. So I don't know what is the literature whether regarding sequence. Let us see. Even I'm not sure about the further slides. So you will also prefer alectinib, Dr. Varun?
Yes, sir. Because it has some better CNS penetration, and so if possible, and if patient is affording, so should go ahead with the alectinib, or otherwise not affording, ferritin also is an option because it also has CNS penetration.
Even if someone has treated the brain with the radiation and all that.
No, already have been treated. Even then, if possible, we should use TKI with CNS penetration because there may be some recurrence. We are giving just SRS. So,
right. So intracranial progression chances are still there. Right. So there are some international guideline recommendation, ALK gene rearrangement. So preferred drug we have category 1, alectinib, brigatinib, and lorlatinib. I think brigatinib is not available with us. So we have two drugs, alectinib and lorlatinib. And another recommendation also, seritinib is also category 1. And in some circumstances, crizotinib category 1. So SRS is recommended for limited CNS disease, right? We have discussed that. So this was about the sequencing part. In ALK positive NSCLC, obviously, whichever drug has the highest intracranial activity and CNS disease control are desirable. So first line lorlatinib followed by chemotherapy, because literature, there's ample literature which says that out of all the TKI which we have today, so lorlatinib has the better intracranial activity, intracranial response. So this is the best to use if we talk about the intracranial response rate. And second algorithm, they say second generation ALK TKI. So I think second generation comes the alectinib, and then the second line lorlatinib, obviously followed by chemotherapy. This is the second. So I think if we were around 4 or 5 years back when lorlatinib was not available, it is there with us since last, I think 3 or 4 years. So second algorithm was the preferable choice. Maybe second line TKI followed by then lorlatinib. So right. So there are some remaining challenges. Liquid biopsy. How to utilize this liquid biopsy in which case, what all cases, and how to get the better outcome. One accurate way of characterizing CNS disease with liquid biopsy through CSF analysis. So okay, I was not sure about the CSF analysis in these type of patients regarding ALK rearrangement. So there is some literature which says that CSF analysis also can be done for ALK this thing. So what overall efficacy or survival, what are the available second line CNS active response rate, these are there. I think we can now come to the main drug which we are going to discuss, lorlatinib. Drug design, we all know that it is a third generation TKI and more advanced, more smarter than the earlier drugs. Selective ATP competitive high potent third generation ALK TKI, and therefore it has got excellent brain penetration, 75% to address the brain metastases. So with this percentage, I think our radiation colleague also will get jealous that no, so much brain involvement is there. But we say if patient is asymptomatic, let us try to give this third generation TKI. And if let me ask Dr. Varun, if intracranial involvement is there at the baseline and patient is minimally symptomatic, minimally means I have seen like just headache off and on. So which gets settled with the painkiller, or we give low dose steroid, and there are brain lesion, 4 or 5 lesion. So and they are not accessible, like not amenable to SRS or surgery. So that way they are amenable to radiation only. So would you refer to radiation? Would you like to get a radiation to the brain, whole brain radiation?
No, sir. No need. I think obviously with good CNS penetration drugs available, why give extra side effect of WBRT? At the
So
program, we
Okay.
may opt for that. If, as I've told already, that we can go ahead with the SRS or metastectomy, that is fine if possible. Otherwise, WBRT we should avoid, because nowadays with these TKIs, patient may live on for years, and with WBRT we know there may be some somatic side effects later. So obviously, with every revaluation, I'm going to do MRI, and if any progression or clinically symptomatic, then we may opt for. But otherwise, no, in the upfront, there is no need for WBRT.
But you said if as far as possible SRS, then you would like to go for SRS, even even in the presence of alectinib and lorlatinib.
As you have told, patient is symptomatic. If patient is absolutely asymptomatic, if some headache is there, so we should treat those lesions. If absolutely asymptomatic, just on imaging, we got to know about these lesions, we may skip any local treatment. But if some symptoms, we should treat.
Okay. And Dr. Hakim, what about your thought process?
Yes, sir. If patient is asymptomatic or minimally symptomatic, I would like to avoid radiation. I would give those later generation TKIs only, because they've got a good CNS activity, and patient may even get into remission even after having a CNS disease.
Right. So that's what Dr. Varun, I was asking you, if minimal symptomatic, you are saying still you would like to go for radiation. Hai na?
No WBRT, maximum to maximum SRS, if one or two lesions. Otherwise, no WBRT.
Because all of us have experience. If we refer to the radiation oncologist, they will never say no.
So obviously, I will not refer them.
So we have seen regarding bone metastasis or so many brain metastases. Once you refer, then patient ko to radiation lagna hi lagna. So that is for sure everywhere. I think it is across world over. This is a practice. So okay. So patient is asymptomatic, or in my thought process, if minimally symptomatic, even then I would try to skip the radiation. It is individual variation. And obviously, we have good penetration, brain penetration of lorlatinib as well as alectinib is down the line a little bit. So its design is like that. I would skip this. Yeah, main landmark study with which they got the approval for the first line setting. That was a Crown trial, and it was published in NEJM 2020 edition by Shaw et al. And key eligibility criteria was stage 3B4 ALK positive NSCLC, no prior systemic treatment for metastatic disease, good performance status up to 2 were considered, asymptomatic, treated, or untreated CNS metastases were permitted. Okay, more than or equal to 1 extracranial measurable target lesion with no prior radiation required. So 1:1 randomization, standard way. 149 patient for lorlatinib, equal patient for crizotinib, standard 250 mg BD, lorlatinib 100 mg once a day. And they were stratified by whether brain metastases were there or not at the baseline setting, or even with the ethnicity. So primary endpoint was PFS by the what they call it, BICR, independent review, something like that. So I forgot the BICR full form. Yeah, blinded independent central review. And secondary endpoint, they came by the investigator, PFS. Oral response rate by, again, blinded independent central review, and oral response rate by this thing, investigator. So there were 2 outcome of all these by the independent review board or investigator: oral survival, then safety and quality of life in the end. So these were the demographic profile of this trial. Of all the patient in intention to treat population, all the, I think, is 300 patient, 150 approximately in each arm. Average age was 60 years. Female was more, surprisingly. Not surprisingly, it's more in female ALK positive, right? 56 versus 44. And white Asian were in equal population. This is good point over here, that Asian population was in good number, equal number. And the smoking status was never smoked 50%, previous smoker 30-40%, current smoker also there some percentage, around 6 to 9%. So stage 4 mostly 90-95%, and adenocarcinoma mostly 95%, and use of previous anti-cancer drug around 6 to 8% in some cases. brain metastasis at baseline, they have 26% in lorlatinib and 27 there. So literature says 20%. So I think this trial, they are saying we can still have at the baseline up to 26% brain metastasis. So prior brain radiation in 6% patients. So first they have 18 months follow-up data, 1.5 year follow-up data. And in this data, they have shown that progression-free survival by independent review board, they have shown that good hazard ratio of 0.28. And if we talk about lorlatinib, so median PFS was not reached by that time. On the other hand, we have 78% for the crizotinib. So they have compared the good drug, first line TKI only. It was not the chemotherapy arm. So they have compared with the crizotinib. So with lorlatinib, PFS was 78%, with crizotinib 39%. So it is almost double the PFS at 12 months with the lorlatinib. And if we talk about by the investigator of this trial, and event outcome was almost similar in the sense that 12 months PFS rate was 35%, and with the crizotinib, with lorlatinib, it was more than doubled. So it was 80%. So it increased from 35% to 80%. And we can very well analyze the curve which are separating apart even after that. If we see a 2-year timeline, there are more separation. And if we go beyond that, they are more separating apart. So separating apart in the sense, lorlatinib has achieved the plateau and crizotinib is going down. So there is more separation beyond a 2-year or 3-year. We'll come to that. By 18 months data, so this is a subgroup analysis. If we talk about the brain metastasis were there or not, by the ethnicity, Asian or non-Asian, male or female, smoker, non-smoker, adenocarcinoma. So all these subgroup analysis, they are saying that lorlatinib is better than, much better than crizotinib. We can see this square one on the this curve. They are more behind this line, center line. And overall response rate, if we talk about all the patients in taken together by independent review board, it is up to 76% with lorlatinib as compared to 58% with crizotinib. But intracranial response rate, we can see the difference. This was a systemic difference, like objective overall response rate, just like 20% benefit over and above the crizotinib. But if we talk about intracranial overall response rate, it is 46% benefit, like it was only 20% with crizotinib response, and here it is up to 66%. So that much was a remarkable response to the lorlatinib in the brain lesion. So time to CNS progression was also very much prolonged with the lorlatinib rather than the crizotinib. So this is the cumulative incidence CNS and non-CNS progression at first event. We can again see the curve, which are really separated apart in terms of this intracranial event outcome. I mean progression. So 12 months crizotinib is showing the 44%. On the other hand, 12 months lorlatinib is showing just 15%. Here also in progression, intracranial progression, they have a benefit of around 30%. So less chances of having the brain lesion. So overall survival, although in the long run, curves are merging. So I think at the time of data cutoff, they say this data is still evolving. Hence the gap between group difference in overall survival was not significant. So safety analysis, which we are more concerned, efficacy we have seen, we have realized that it is very good efficacy beyond doubt. There is no comparison, even with the alectinib. But here is the some concern in the safety profile as per the literature at least. So any grade adverse event we see 100%, grade 3 or 4, 72% with the lorlatinib and 56% with the crizotinib. Serious adverse event are also more, 10% higher with the lorlatinib. Fatal adverse event are almost similar. So discontinuation rate are also similar. Dose interruption also similar because of side effect profile. So this is a unique outcome. I think I am seeing first time all casualty adverse events and all calculated with more than 10% difference in frequency. They have mentioned this long list: hypercholesterolemia, hypertriglyceridemia, edema, weight increase, peripheral neuropathy, cognitive impairment, hypertension, vision disorder. So all these side effects they have mentioned, even LFT alteration, hyperlipidemia, dysgeusia. So all these side effect profile are there in this with the lorlatinib. More concerning is that they have given very high percentage of grade 3 and 4 with the lorlatinib of all these side effects: hypertriglyceridemia, mainly lipid profile, and even LFT alteration. So then later on they come up with a 36-month follow-up data. And even at 36 months, if we see that, we can see that the curve was almost parallel at that time. So 18.9 months with the crizotinib and 63% with the lorlatinib in the intention to treat population. That much is the PFS benefit. Huge difference. So response wise, it is remarkably very good. Even in the subgroup analysis, still at 3-year timeline, this is still favoring the lorlatinib. Even the intracranial response rate, they are better than crizotinib, much better than crizotinib. But yes, we don't have any trial head-to-head with the alectinib, which has got some also good CNS penetration. So there is no head-to-head as per alectinib. But yeah, benefit is much higher, as you can see even at the 3-year timeline. So summary of overall and intracranial response rate. If we talk about lorlatinib, 150 patient, confirmed overall response rate 77, complete response CR is seen in 2.7%. So this is one remarkable difference, that even with lorlatinib we are able to see complete response rate, that is 2.7, but not with crizotinib, not even a single one. So that is the beauty of this newer drug. And if we talk about adverse event,
Am I audible, Danny sir?
Hello. Yes, sir, you're audible. Sir.
I think Danny sir का sound नहीं आ रहा है ना?
Yes, sir, some network issues I get.
I think sir का
He
disconnect.
disconnected. Yes.
Okay. Yeah, Dr. Danny is connecting. I think there was some technical glitch.
Yes, sir. Okay, sir.
I discussed with Dr. Danny. He is joining.
Mhm.
Am I audible?
Yes, sir.
Yeah. Sorry, my connection was out. So I
Hmm.
think we have discussed about all these things. So this was the thing which I was saying, that as per the standard guideline, we have options which we have earlier discussed also. And so there was some another meta-analysis which they have come up and called that the network of evidence, in which they combined all the trial like Ascent 4, in which Certini was used as a second line, then Ascent 8 also, in which drug dose was reduced for 50, then brigatinib Alta 1L, ALX trial, JLX Crown trial. So all these meta-analysis they have come up, and in that also they have shown that relative effect of lorlatinib compared to all treatment. So in this trial, so this graph is also showing no statistical difference between lorlatinib and other treatment for overall survival, and although this was immature for most of the studies. So what are your impression of Crown adverse event data, and how is your experience? So experience wise, as we have discussed, all three oncologists, that even I don't have any experience of lorlatinib adverse event. And although they say that they are reversible, are this significant concern for first line? Definitely, for me at least, they are really concerned, because incidence wise they have shown very high number, like up to 60% these side effect profile, and but they are well manageable as per the literature. But what are the guidelines? They say therapy management for hyperlipidemia. Obviously, we have to start the statin and monitor the cholesterol and triglyceride levels. And yeah, some patient do have even hyperglycemia, so they are guideline to reduce the doses. So we have to, I think, before starting lorlatinib, we must do the lipid profile, even cardiac profile, liver profile upfront before starting, even sugar profile before starting this lorlatinib. So all these 4-5 concerns are there regarding this lorlatinib. So these are the things. And resistant pattern, yeah, this I touched upon earlier, and this is good data publication, that all these mutations were found after ALK. So most common after first line, we discussed L1196M mutation was there, and it was addressable by the second generation TKI also, but G1202R was not addressable by second generation TKI. It was addressable by lorlatinib only. But problem here is that we are more likely to have combined mutation. Combined mutation means even some other mutation along with G1202R. So even lorlatinib may not be effective in those scenarios once patients have got compound mutations as a resistance mechanism. So this was a sequencing which we used to discuss for EGFR. So let us discuss in there. First, someone, if you have used the crizotinib as per the profile 1014, 10.9 months PFS. Then second line certinib, we have lorlatinib. So it was just 6.9 months benefit as a third line setting. So I had one patient around 4 years back. It was put on lorlatinib at under Dr. Sham when it was under trial setting. So, but that time patient did not survive for long on third line lorlatinib. So he took just for 2 months, and then I lost that patient. That was the minimal experience with lorlatinib. And then they have come up with the brigatinib. So it also seems to be very promising drug, 16.7 months PFS. And then certinib first line is showing 16 months, and brigatinib is showing 24 months. So better than rest of the second generation TKI. Obviously, lorlatinib is showing the maximum PFS benefit out of all these generation, and it is I think it's the only drug in the third generation ALK TKI. Obviously, followed by we can go for chemo, radio, or immunotherapy, depending on PDL1 is there or not, and even performance status. So more or less, some literature are saying that patients with ALK positive patients are going to survive beyond 5 years, 6 years also. So average survival, they have said it is like 6 years or so after using all these, I would say, permutation and combination. So thank you. I would stop here. So I would just like to ask the organizer from the company side about the side effect profile, what feedback they have from the other oncologists whosoever have used this drug.
Sir, as per discussion with other SCP, I think safety profile are very much manageable.
No, it was very much manageable. It is there in the literature also. Whether they do also have the maximum incidence about of this triglyceride, cholesterol, glucose. So their practical experience is the same.
Yes, the practical experience is same, and they start, sir, just as you discussed, sir, in this meeting. Before do start with lorlatinib, they do all the tests like cholesterol and ECG, whatever the requirement is to put the patient on lorlatinib in the first line setting, sir.
Yes.
I think
So,
sir, it is just like this as initially at the onset of IO drugs, we very much scared of the IO related side effects. Similarly, hyperglycemia with alpenicillin. So same here with the experience, maybe we will be more comfortable with the drug. Obviously, we will do some dose modification. Maybe in some center, we will start with some low dose and then increase the dose in some patients. So that all, but most of the time, these side effects should be manageable. These are like hyperglycemia, hypertriglyceridemia. So these look like that we can manage that. But just have to be more monitoring should be more focused and rigorous.
That's what I was saying now, Dr. Varun, that this drug has been marketed since long. And even today, I'm not having any idea what is the actual experience by our colleague. So I would request the company people to compile some data. So how many patients you may be having all over India? Rajesh?
Sir, in Delhi, sir, we have around, sir, 40 to 45 patients currently who are taking this
As a
therapy.
first line setting, right?
Sir, no. So we can't comment, sir, regarding the first line setting, which we have to check. But in current scenario in Delhi, I think 40 to 45 patients are going on.
And
I
sir,
will
just
discuss.
just want to add, sir, one more point, like you said about side effect profile, sir. The doctors who have used it extensively, they are saying that only hyperlipidemia is one thing which they usually see with this drug, and which is manageable. They started in their practice, they started giving rosuvastatin after 15 days. So they are not waiting for the side effect to come in, but they proactively give rosuvastatin. So this will keep patient intact. And secondly, sir, the second side effect is weight gain, which is also seen in many of the patients, but it is also manageable, sir, by dose reduction or something like that. And
I have a query.
Yes, sir.
As
And
we know,
in one of the meeting, yes, please.
As we know, hyperlipidemia is the most common side effect, but that is manageable. We can give anti-lipidemic drugs, anti-hyperglycemic drugs, so that's managed. But what about those neurocognitive effects?
So, sir, as far as my discussions with the clinicians, sir, there are not much patients who have these kind of side effects.
I want to know whether neurocognition, is it reversible or it is irreversible?
Sir, as per my discussion, sir, it is definitely reversible. If you stop the treatment or reduce the drug, so it is reversible, sir.
So, Rajesh, the way we are discussing today, it would have been better if you have compiled the data in Delhi, NCR, or North India, or all over India.
Yes, definitely, sir. Next time,
must
sir.
Put for some slides that actual hand-on experience, so that we must be rest assured, because literature is really panicky sort of thing, which is saying, I don't know. So इसीलिए ना मतलब जो भी experience है, so you compile the data and someone can present whosoever use the maximum number of patient, है ना?
Definitely, sir.
So that will give more positive feedback.
Yes,
Yes.
sure, sir. We got your feedback. Yes.
चलिए एक बार इन द एंड में एक बार कॉस्टिंग फैक्टर फिर से बता दो यार. आई एम नॉट श्योर अबाउट द कॉस्टिंग फैक्टर.
Sir, regarding the cost, the upfront cost is 2.40, and we are offering a 1+1 program. So in this case, upfront cost is 1,20,000 per month, sir.
Okay. And if a dose modification is required, then they will have to buy 25 mg medicine.
Yes, sir. We have 25 mg option also, sir.
So it is easily available, right?
It is definitely, sir. It is easily available for your patient, sir.
Okay.
And sir, I would like to one more thing. When I was in Pfizer, I launched Kizab. That time PFS was only 10 months, and recently data has come as 37 months, and 48 month data will be read out. So 10 months to 48 months, it is possible because of science. Definitely, there is a side effect with this drug, which are manageable. So I request with our medical. Next time we will come to you with all the compiled data regarding, sir, your query, sir.
Right.
And on behalf of Pfizer, sir, I would like to thank sir, faculties and attendees. Definitely, it is an opportunity to gain the knowledge about ALK positive NSCLC. Thanks, Dr. Denny, Dr. Happy, Dr. Varun, who enhanced our knowledge about ALK positive NSCLC. And we have covered biomarker era, ISC versus FIS, management of patient with CNS disease, treatment sequencing, lorlatinib third line ALK TKI, count trial, CNS progression, and resistance pattern. So definitely, sir, we enhanced our knowledge about ALK positive NSCLC. Thanks, Dr. Denny, Dr. Hakim, and Dr. Varun. Thanks from Pfizer side, sir.
Thank you, Rajesh. Thank you, all of you.
Thank you.
Right.
Good evening, everyone.
Bye, Varun.
Good evening, good evening, sir.
Thank you, sir. Bye, sir.
Thank you, madam. Thank you.